Here are some of the trials that we're going to be talking about. Just kind of put in a tabled form. So we're going to talk about all three of these today: Escape, Mr. Clean, and Revascat, and we'll talk about them in detail in just a second. But I just wanted to kind of just show you the overview in terms of when the time of onset, when these were allowed to be enrolled, what type of devices were used, and then how the imaging was important in terms of predicting which patients would do it. So you'll note in a second that some of these studies actually used kind of additional information beyond just CT and CTA alone. Some of them used collateral scoring. Others used software algorithms to help identify core infarct volumes, as in the case of Extend-IA, which is here. We're going to talk just very basically about some of these other trials at the very end of the day. And then Swift Prime, of course, was the last of the 5 that was presented in 2015. So let's get to the trials themselves. So this is that patient that we were just discussing. And so here's the images from that patient. And so you can see, we'll kind of go back to the start there. There's the MCA occlusion that we just looked at on the CTA. And this patient has pretty good collaterals, actually. You can see there's backfilling almost all the way down to the level of the clot, which is really good. And you can see that on the CTA in the sense that you could see there's filling beyond the lesion. Here it is in lateral projection, and there you go. It is approximately occluded, but then there's these retrograde collaterals again filling back in. And then this is after a single pass. And this is what we consider we call TICI-3 reperfusion, meaning that the entire distribution has been reperfused, which is obviously the desired effective intervention. So in this case, the door to kneel time was just 26 minutes, which is great. The door to groin time was 360 minutes, which is a little longer. And you'll see some of the norms as to what we would expect door to groin time is. And then, of course, the post result is a TICI-3 result. So again, let's just now kind of unpack these trials one by one. So we'll start with Mr. Clean. This is the largest and the first to be published. This was just published in the very first of the year in 2015. This is done in the Netherlands, of course. This is the only trial out of all of these to actually complete its desired enrollment. The other trials actually had to stop based off of the result of this trial due to ethical reasons. But the design was a multi-center study, blinded to the assessment at 90 days, modified Rankin, and then obviously blinded in terms of the neuroimaging and the follow-up. And it was a 1-to-1 randomization to patients with intraarterial treatment, mechanical treatment, or both. Obviously, the control group received, medical therapy as would be prescribed in terms of IVTPA. In terms of the inclusion criteria, obviously it's acute ischemic stroke. You had to be an adult, and you had to have a stroke scale just above 2. And this is going to be important because we'll start to see some of the subtleties of where stroke intervention is more impactful and less impactful. It has to be in the anterior circulation as confirmed by CTA. And again, this is important because we used an imaging modality to really locate where the occlusion actually was. And you had to, of course, initiate treatment within 6 hours from symptom onset. So here's just the randomization algorithm, just showing how they started out with 500 patients, 233 ended up in the intervention arm, 267 in the medical arm. Should be noted, a small percentage of patients in the intervention arm actually never received intraarterial or received intraarterial therapy, but nonetheless, the assessments were still powered sufficiently to make very, very strong claims. So here are the two intervention groups, and they're reasonably matched in terms of no statistically significant differences between these groups in terms of their stroke scale, their age, their gender, and of course here's that aspect score that we talked about. So this is a relatively high aspect. It's almost perfect. In terms of where the lesions were located, again, most of them are in the M1. You can see here, though some of them were in the ICA terminus, and then even fewer were in the M2 and of course the A2. In terms of time from onset to IVTPA, you can see here we're just over under an hour and a half, and time to groin puncture was just over 4 hours. And so you're going to see how this is going to be really important later on in terms of how sizable an effect you get. So we'll kind of come to that toward the end in terms of the summary. So again, this represents stent retrievers in large part. Almost all of the patients underwent stent retriever. Some patients underwent other types of mechanical intervention. I should note that there are other types of mechanical intervention, including aspiration therapy, as well as other types of stent retrievers, but ultimately the majority of those treated in the United States is done by some type of stent retriever. In terms of the angiographic outcomes, most of the patients received either a TICI 2B or TICI 3 result. Again, a 2B is more than 50% reperfusion of the targeted territory. And that's really what we want to do. And then, of course, the big thing, which is not surprising, is that you are much, much more likely to get some sort of recanalization angiographically if you went on intervention than you went on a control. And again, that harkens back to what we talked about at the beginning of the presentation as it relates to the limitations of IV-TPA to really break up large vessel occlusions. So here is the plot that everybody is always interested in seeing, which is the modified Rankin effect. And so what you can see here is that for those patients who underwent intervention, we had a significantly higher number of patients with modified Rankins inside the 0 to 2 arm than we did in the control group. And you can see the adjusted odds ratios here. Of course, you want to ask them about the adverse events. Are we exposing these patients to initial harm? And the idea here is that ultimately we're not. The symptomatic hemorrhagic rate was essentially the same. There was some new strokes into other territories, but this is more an effect of the treatment itself, obviously, than the disease is left untreated by intervention. But then the medical therapy or the medical complications were not that dissimilar. The death rates were not that different at all. So the Mr. Clean study conclusion is the most impactful of all of them. That's why we always start here. And what this really just showed with very definitively that if you could affect a large vessel occlusion, an ICA M1, or even proximal M2 within 6 hours of onset, this was safe and extremely effective. And so, again, this leads to greater functional independence at 3 months without a significant increase in mortality. Retrospectively, they also looked at the importance of collaterals. I should note again that the Mr. Clean study did not use collaterals as a way to include or exclude patients. But when they went back and looked at patients based off a collateral scoring scale of 0 to 3, they did very much find that you had a over 3 times better chance of having a good outcome with good collaterals, meaning that you had filling all the way back to the entire distribution of the affected area versus those patients with essentially no collaterals. There was essentially no effect. And you'll see that how this plays out, obviously, in some of the other trials. But again, this is an important retrospective result to note in that collaterals are extremely important in terms of patient selection and how they may do long-term after or even short-term after a stroke intervention. So the ESCAPE trial, this was published soon thereafter. This is, again, just in February, just a month later, again in the New England Journal. This is different than Mr. Clean in the sense that it's a smaller study. Again, it's international, multi-center. But instead of just looking at large vessel occlusions inside 6 hours, they also wanted to look at some of other advanced imaging elements to be able to predict things. So you'll see that now our NH stroke scale is up to 5 instead of less than or just 2. They did have functional, presets prior to allowing patients to kind of come in, to the study. And they had to have moderate to good collaterals on CTA. So this is important because if we were to use these same criteria on the Mr. Clean study, a lot of the patients that were enrolled in Mr. Clean, or at least a certain percent of them, would not have been able to be treated. And so this is important when we get to the kind of the conclusions here. But again, the one thing that they also did, in addition to kind of like using imaging to help better predict patients, they also really, really made an emphasis on the rapidity of how quickly the team assembled, but also how quickly the intervention was done. And you'll see how that played out in the result. So again, they did a consecutive patients. They were not trying to obviously take the best cases. And what they wanted to show was that if you have a small core with a prosecution and good collaterals and you're very quick, you can have good outcomes. And so here's their randomization schedule. They started with 316 patients. You can see it's a smaller number, but again, they had to stop this trial early because of the Mr. Clean result. So here are the two groups. And again, the randomization scheme looks very, very consistent in terms of the baseline medical therapy, comorbidities, gender, and of course an NH stroke scale, which is here. In terms of imaging, again, CT aspect score, again, very important. It's high in both patients. And again, most of the lesions are going to be M1. They started recording ipsilateral carotid occlusion. Mr. Clean did this as well, and you're going to see that this is going to come up and again. We don't have a great answer to this. We're going to talk about that a little bit at the end. But ultimately, about 10 to 20% of patients will also have a cervical occlusion of the carotid artery, and those can be more difficult in terms of not only how to treat them, but how they perform or how they respond to therapy in general. So in terms of time parameters, you'll see how quickly they are in terms from time from CT to brain puncture. Now, granted, they've kind of separated these times into different things, but even nonetheless, you can see that 260 minutes from time to brain puncture, they were able to do the whole thing to reperfusion in a lot less time. And so this really speaks to the emphasis on the teamwork and like the multiple disciplinary elements that stroke requires in order for the system to work well. There's that just being highlighted there. So again, the majority of these are going to be stent retrievers. There was a smaller percentage increase in the other mechanical types. And again, we're about 70% of patients were having 2B or 3 type recanalization results, which is again, not surprising compared to IVTPA alone. So in terms of modified Rankine, 0 to 2 at 90 days, 53% versus 29% in terms of the intervention versus the control group. So this is just the absolute data. And this is that same plot that we saw with the Mr. Clean important result. And just again, showing that, this is really impactful for these patients. We have a much significant number of these patients being independent at 90 days than otherwise. In terms of the safety endpoints, the intervention group was actually lower, meaningfully lower than the control group. And in terms of the malignant type of MCA syndromes, obviously that would be expected to be lower as well. The symptomatic intracranial hemorrhage rates were not that dissimilar, slightly higher in the intervention arm than otherwise. And obviously there's some access-related issues and then mechanical issues from doing the intervention itself that you would not expect to see in the medically treated arm. So from a conclusion standpoint, again, ESCAPE kind of underscores the safety and the efficacy of intervention, but it also really kind of gets to the idea of you want to treat these patients as fast as possible, and that ultimately these collaterals of these additional imaging adjuvants are really important in terms of trying to predict who will respond well to a stroke intervention. This brings us to SWIFT Prime. This is published in the same New England Journal in February of 2015. This is a US-based study. Again, this is looking at stent retriever-based intervention. Patients need to be treated within, or at least start of treatment within 6 hours of symptom onset, and it's again being compared to those patients with IVTPA. So here you go. Here are the inclusion criteria. Now the aspect score is again greater than 6. NIH stroke scale is at least 8, 29. And again, it had to be started within 6 hours and 90 minutes from CT or MRI to groin puncture. So again, you're seeing an emphasis on time in terms of the inclusion criteria. Here is their randomization schedule. Again, it's an even smaller number of patients, again, in part because this study was stopped because of the Mr. Clean result. Here are the baseline characteristics, again, very similar in terms of their age, gender, NIH stroke scale, and their medical comorbidities. Again, baseline imaging is comparable to the other studies, aspect scores, which are very good. 9 is a great score. And then obviously most of these patients have M1 occlusions. So in terms of time parameters, you can see here that they're even faster than the MR Clean or the Mr. Clean study, and slightly faster even still than the ESCAPE trial, which is good. And so again, it speaks to the ability of people to work together quickly to identify patients and get them through the system fast. And again, as a result, we see even higher numbers of patients getting excellent reperfusion rates. This is almost 90%, and almost 70% getting TICI-3, which is wonderful. Again, here's reperfusion at just over 24 hours, not surprising, greater than 80% in the intervention arm, and only 40% in the IV medical arm. So again, here's that plot showing the effect for patients in terms of independence at 90 days. And again, here's your odds ratio with only a number needed to treat of 4 for patients to retrieve some sort of benefit, which is fantastic. And so here you can see in terms of the outcome, 60% versus 35% versus in the medical arm. So in terms of the safety endpoints, again, they're comparable. In this case, the death rate is actually still lower. Any sort of serious adverse events rates was a little higher, but again, it is an intervention. So we do have to deal with groin issues and other types of mechanical events that can occur when you're intervening in the head. But again, the symptomatic intracranial rate was actually less in the intervention arm, which is great. So again, the conclusions are comparable to the other two studies, but again, these are all happening, it should be noted, all kind of being presented at very close to each other. So it's not that these are building on each other as much as they're just echoing each other off of the results and the technology that we're now seeing used in clinical practice.